Ladies and gentlemen, thank you very much for the invitation to speak today about functional dyspepsia and gastroparesis. I'm going to try and convince you that we are beginning to understand the pathology of functional dyspepsia, but there remains great confusion about the differentiation of gastroparesis from functional dyspepsia. And I'll cover all of these areas in my talk today. These are my disclosures. So first of all, definitions. Functional dyspepsia is a clinical syndrome based on a cluster of symptoms that arise from the gastroduodenal region. There are two subtypes: postprandial distress syndrome, characterized by early satiety and/or postprandial fullness, and the epigastric pain syndrome, characterized by pain or burning in the epigastric region. Of course, many patients have an overlap of both PDS and EPS. The other key point to mention is functional dyspepsia overlaps with the irritable bowel syndrome. Perhaps more than 50% of patients with IBS also have functional dyspepsia symptoms, implying they share a common pathogenesis. Severe functional dyspepsia, the severe end of the spectrum, is actually very poorly defined. But in this conceptual slide, I've suggested that severe functional dyspepsia is the subtype where there is indeed increased comorbidity, more IBS overlap, more psychological distress, a higher impact on quality of life, more impairment of work. Where exactly the symptom thresholds should be drawn to identify severe from non-severe functional dyspepsia is not clear in the literature, although there is work ongoing in this area. We know functional dyspepsia is remarkably common. 7 to 15% of the population have functional dyspepsia symptoms. This, for example, is the survey using the Rome 4 instrument in multiple countries to identify the prevalence of functional dyspepsia. Notably, postprandial distress syndrome subtype is the predominant subtype. And this is confirmed with endoscopic studies of population samples. For example, this work from Sweden that we did showing that functional dyspepsia affects about 16% of the population, and the majority again have postprandial distress syndrome. Now, what's the pathophysiology of functional dyspepsia? And a number of factors have been thought to be important in the pathogenesis. This includes gastric acid, which is why we often use acid-suppressing therapies. I'll come back to that later in the talk. H. pylori eradication, although H. pylori appears to be associated with pain, but not early satiety or fullness necessarily in functional dyspepsia. Motor changes are particularly important in some patients. About 1 in 4 functional dyspepsia patients have slow gastric emptying, and nearly half have impaired fundic relaxation, which also impacts treatment choices in some cases. And I'll come back to a very important new feature of functional dyspepsia: inflammation in the duodenum. And in fact, that's been, I believe, one of the important breakthroughs in understanding functional dyspepsia, the finding that there is low-grade duodenal inflammation in patients with this syndrome. And increased eosinophils, they can occur in clusters, the number of eosinophils has increased, and there's also evidence of eosinophil degranulation and damage to the nerves present in the duodenal submucosa. And this work's been done by us, by the group in Leuven, led by Jan Tak and colleagues, and by other groups around the world that have confirmed these findings. More recently, we presented work at Digestive Diseases Week, this was last year, where we showed a study from the United States in 20 centres. We screened patients who had chronic GI symptoms, mostly functional dyspepsia type symptoms, with or without diarrhoea. And these patients were offered an endoscopy, which was performed in these patients, 405 patients from 20 sites. And here we found, again, evidence of eosinophilic duodenitis in a group of patients. 45% met histologic criteria, compared with only 6% of the controls. And so, at least in this study, a strong association between eosinophilia in the duodenum and chronic upper GI symptoms. So what may trigger this inflammatory process in functional dyspepsia? And the answer is we're still learning about it. But possibly infections are important. We know gastroenteritis can lead to functional dyspepsia and or irritable bowel syndrome. There's also recent evidence in this study from India that SARS-CoV-2 is a risk factor for the development of functional dyspepsia and or irritable bowel syndrome. And this may be because there's a change in the microbiome of the upper small intestine, although that remains to be proven. What we do know is in functional dyspepsia, there is evidence of increased small bowel bacterial overgrowth by breath testing or by duodenal aspirate, and using techniques like 16S or shotgun, evidence of a change in the duodenal microbiome present in functional dyspepsia. So this is an exciting area of research as it's possible to manipulate the microbiome. The other hypothesis that's under scrutiny is the idea that non-IgE food allergy may be relevant in the pathogenesis of functional dyspepsia. There's work in IBS, for example, that certain food antigens can definitely drive IBS symptoms and pathological changes in the duodenum. And there's been some very recent work on this also in functional dyspepsia patients showing similar changes, suggesting that non-classic food allergy may be relevant in the pathogenesis of at least a subset of patients with these syndromes. So how do we manage functional dyspepsia? Well, standard approach is to identify and treat Helicobacter pylori, to give a acid suppression therapy if patients do not have H. pylori infection or fail to respond to H. pylori eradication therapy, followed by the option of either a tricyclic antidepressant in low dose or a prokinetic. But there are additional options that are also potentially worth considering. Dietary therapy, for example, and stopping smoking may be relevant in some patients. And there's also data on other approaches that I'll cover very briefly now. That includes proton pump inhibitors. There's now very interesting evidence that PPIs are anti-eosinophil therapy and in the duodenum decrease duodenal eosinophilia, which correlates with symptom reduction. So proton pump inhibitors may work in functional dyspepsia, but not through acid suppression alone. There's also evidence that blocking histamine may be relevant in functional dyspepsia and irritable bowel syndrome, work that suggests that both the old H2 blockers and possibly a combination of H1 and H2 blockade may provide some value. Low-dose tricyclic antidepressants like amitriptyline do appear to provide a benefit for symptoms in functional dyspepsia. And then finally, targeting the microbiome may be of value, and there is some emerging evidence that rifaximin, for example, or probiotics may provide benefit for symptoms in this syndrome. And the prognosis of functional dyspepsia, well, it's clear that some patients will remit spontaneously, some patients will develop irritable bowel syndrome or gastroesophageal reflux, and therefore these syndromes are likely all interrelated. But there is also evidence that there's no increase in mortality in functional dyspepsia. So let's turn to gastroparesis, because this actually is very confusing. In the literature, gastroparesis is defined as slow gastric emptying and typical symptoms, but most of the typical symptoms are exactly the same as the symptoms of functional dyspepsia, with the exception that vomiting and weight loss is much more prominent in gastroparesis. Some people have used the term gastroparesis-like syndrome for symptoms that are suggestive of gastroparesis, but gastric emptying is normal. This, frankly, is completely indistinguishable from functional dyspepsia. The same applies to the chronic nausea and vomiting syndrome. So this is a very confusing area, and the literature is actually really inconsistent. There is work on gastroparesis defined using strict criteria, which suggests actually it may well be very rare. This is work from the Mayo Clinic suggesting the age-adjusted prevalence of gastroparesis was very small, around about 10 per 100,000. But what was interesting in this study is in this severe subset, there was evidence of increased mortality in gastroparesis, unlike functional dyspepsia. The pathogenesis of gastroparesis, well, the studies that have been done have only focused on severe cases that have had full thickness biopsies. And in those cases, there is evidence in some, about half, of gastric pathology. For example, loss of the interstitial cells of Cajal, the pacemakers of the stomach, that occurs in gastroparesis. But what's interesting is in animal studies, even if you lose ICCs, this may not be accompanied by a change in gastric emptying. There's also work from other studies in diabetic and idiopathic gastroparesis that CD206 macrophages may be relevant in the pathogenesis, and a loss of these anti-inflammatory macrophages may occur in gastroparesis. And then there's been some very interesting work, speculative largely, but still very interesting, that perhaps some cases of gastroparesis are related to viral or other infections. And indeed, there's some work, for example, with enterovirus that suggests this might be important. And some uncontrolled studies which suggest some patients who receive antiviral or immune therapies with this syndrome may improve, but again, uncontrolled studies. So how do we treat gastroparesis? Well, basically we use a dietary approach, a low-fat, low-fibre diet, maybe homogenising the food, tight control of diabetes, as diabetic gastroparesis is also possibly a different syndrome to the idiopathic subgroup, which is larger. Prokinetics and antiemetic therapy combined is worth considering. And then if that fails, alternative therapies can be considered. However, in gastroparesis, nortriptyline at least was a failure in terms of symptom improvement. So again, in contrast to functional dyspepsia, perhaps gastroparesis is not a condition that responds to tricyclic antidepressant therapy. And here's the data with nortriptyline, just showing again no benefit, surprisingly, in gastroparesis, idiopathic gastroparesis. So how do you tell if a patient has functional dyspepsia or gastroparesis? And the answer is you don't. The experts are as confused as you are. Really, you cannot tell the difference, essentially. The key symptoms of functional dyspepsia, early satiety and postprandial fullness are the key symptoms in gastroparesis. 2, functional dyspepsia symptoms correlate very poorly, if at all, with slow gastric emptying. And the Gastroparesis Consortium showed over a 48-week period that the finding of slow gastric emptying is not consistent in about 40% of patients. In other words, you can't rely on a gastric emptying test, a single test, to identify true slow gastric emptying that is persistent. I think gastroparesis is largely overdiagnosed, and many patients who are said to have gastroparesis actually have classic functional dyspepsia. There's no mortality associated with functional dyspepsia, and they'll do fine with standard treatments for functional dyspepsia. So there are many unanswered questions in terms of gastroparesis. Should we change the terminology to differentiate gastroparesis from functional dyspepsia more clearly? We do not know if the duodenum is abnormal in terms of structure or function in gastroparesis. We do not know if eosinophilic duodenitis is actually a mechanism for gastroparesis. We don't know if systemic immune activation occurs in gastroparesis. So this is a very exciting time in terms of research, in terms of practice. I think taking a pragmatic approach and diagnosing functional dyspepsia, unless there's severe vomiting, nausea, and/or weight loss, is a very reasonable tack to take. Thank you very much for your attention.